is there any health benefit of alcohol? The answer is a
So clearly, steatotic liver disease is redefining the boundaries between the specialties.
It's not like a T20 match. You have to have a kind of a sustainable approach to lifestyle modifications. Live your life, but love your liver.
So welcome to the program, Doctor, and it's a pleasure to have you.
Morning, Dr. Lakshmi.
So every time I meet you, it feels like I'm talking to a walking encyclopedia. Has anyone said this before?
No, that's not true. I'm sure there are more learned people than me, but yes, we all try to keep ourselves up to date with whatever is going on in our specialty. You know, my main area of interest is liver transplant, so you need to have a fair amount of idea of what's going on in other fields too. So I think it's a good idea to stay abreast with the knowledge explosion.
So today, on the occasion of World Liver Day, so what's new in the field of hepatology? Can you just throw some light on it?
So I think that's a wonderful question. So the most noteworthy change that has happened in the last few years has been with one of the conditions which we used to see very commonly in our day-to-day practice and about which we have talked in our earlier conversations, which is the fatty liver disease. So I think this is one particular entity which has undergone a huge change in its definition, the nomenclature, the profile, and a general approach to the patient. So as you and your audience are aware, all these years we used to call it the non-alcoholic fatty liver disease. And there were issues with regards to this particular name per se, you know. So when you start coining a term with a non at the beginning, it almost sounds like exclusionary. That means you have to exclude a number of things before you are trying to make a point as to what you are talking about.
It doesn't sound that serious,
Yeah,
maybe.
so it and at times the patient would always ask you or come back and question you that why could not it be something else. And then there were at least two stigmatizing words in this acronym, which is alcohol and fatty. And oftentimes we people have reservations about talking about alcohol, though it's something and it's probably the commonest recreational substance that we use. I would not say a drug of abuse or something that is abuse, but recreational substance of abuse. Let's try to not rub people the wrong way and call it like that. And then fatty. So again, it's not such a kind thing to call people fat or fatty, and oftentimes it was perceived that if you had NAFLD or NAFLD, then you were supposed to be fat, which is not true and which we have discussed on earlier occasions. So now we call this whole group of subjects, not everyone is a patient, as steatotic liver disease. So steatotic comes from the word steatosis, which means fat. So if you have got fat in the liver, we just say that the subject has got SLD, steatotic liver disease.
Yes, rightly said. So we are no longer body shaming or organ shaming as we...
Absolutely, absolutely. That used to alienate our patients. So whether you were trying to, sermonize somebody on the amount of alcohol and duration of alcohol they were taking, or you wanted to just call somebody, fat or obese. So these are the terms that probably they don't sound right. And I think in the last conversation I had with you, again, we had discussed this, that we should not be body shaming anyone because this is physiology. So this is not a choice all the time.
So as you've mentioned, steatotic liver disease, it's more often a silent disorder or a silent disease.
So that's a wonderful question. So I think oftentimes the subject who's coming to our clinic would have gotten a scan done for a completely different reason. So most of the times the symptoms are not related to the liver affection per se, and these patients have got rather non-specific symptoms. So and again we've discussed this earlier, the commonest symptom of liver disease is actually fatigue, which is something probably all of us would be having. So it's so non-specific that it's really not worthy of more workup. So these patients, why this is silent is because the fat takes a lot of time to accumulate in the liver, and when the fat accumulates in the liver, you get very non-specific symptoms. The commonest, if you probe and pry, the patient would say that yes, he feels probably some vague pain or ache or dragging sensation in the right upper part of the abdomen. But that apart, it's just incidentally picked up.
The alcohol there's a lot of stigma attached to it, and we rarely see people talk about alcohol abusing. So what amount of alcohol do you think is actually toxic to the liver?
So if your question were to be, is there any health benefit of alcohol? The answer is a plain no. There is absolutely no health benefit of alcohol, any amount of alcohol for any subject. However, you still cannot change the world order, so it is not going to be that somebody listens to this podcast and the whole world is going to, say that yes, we are going to become teetotalers. That's not going to happen. So that is why the alcohol that you consume, the amount that you consume, and the pattern of alcohol consumption. So the pattern is far more important than what you are doing. So what one means by the pattern of alcohol consumption is, so earlier we used to have two particular terms defined. So one was called alcohol abuse and one was called alcohol dependence. Now in the new terminology, we have done away with these terms. So we now have one kind of a umbrella term which is called alcohol use disorder. That means you are taking an amount of alcohol which is probably making you lose control. So the whole problem starts when you lose control over the amount of alcohol that you take. Now if somebody already has a risk factor, and say somebody has got a steatotic liver disease because of some other reason, which are the metabolic reasons, and then you are taking alcohol, then obviously the injury is going to be much more severe. So as you can see on this particular slide, we as doctors do not talk about the volume of alcohol consumed, but we talk it in terms of the grams of alcohol consumed. So for a lady, 1 drink per day, and for a man, 2 drinks per day, which would be tantamount to 7 drinks per week for a lady and 14 drinks per week for a man. That would constitute as what is called as a modest alcohol consumption. But again I said this modest could also go awry for you if you have got other metabolic aberrations. Anything above that is called at risk alcohol consumption.
So the bottom line is no amount of alcohol does good to your body anyways.
Yes, health wise no. So there could be other things that people might be interested in, socializing, just getting together, and reasons for engagement, but health benefit absolutely no.
So has the steatotic liver disease, has it got to do something with people who do not drink at all?
Yes, so that's what I said. So steatotic liver disease at the far left of the spectrum is only metabolic aberrations. So that means you are overweight to obese, you are hypertensive, you have got high triglycerides, you have got an increased waist circumference, you have hypertension. So all these are components of the metabolic syndrome. So obesity, type 2 diabetes, pre-diabetes, hypertension, visceral fat or belly fat or increased waist circumference, dyslipidemia. So these are the common denominators for any of the components of metabolic syndrome, which also have a bearing on the amount of fat in the liver.
So clearly steatotic liver disease is redefining the boundaries between the specialties, as you've mentioned.
Absolutely, absolutely, and that is so important for our practice, because oftentimes, at least in an organization like ours, where we see not patients so much from the community as patients referred from other institutions, and oftentimes patients are referred for liver transplant when they have end-stage liver disease. So this is a completely different cohort of patients, so they need to be optimized. So as we know, and now this particular entity is called Cardio-Hepatic-Renal Metabolic axes. So that means all of them are intertwined.
So which means that a patient can potentially be having a liver disease but still would be presenting with other symptoms pertaining to the other systems.
Yes, yes, that's so true, and I'm glad you asked that question. So all these years when we used to see our patients' evaluation for liver transplantation, and our cardiologists are fantastic. We have got dedicated cardiologists who look at our transplant evaluation patients. But if you read those reports pretty much read the same thing. What we call as heart failure with preserved ejection fraction or diastolic dysfunction. So that is all stemming from the fact that there are metabolic abnormalities. Those metabolic abnormalities have an impact on your cardiovascular status, and those metabolic abnormalities will have an impact when you are going to take your patient through the stress of a liver transplant surgery. So if you were to ask me one question, what defines the short-term outcome of a advanced liver disease patient, the answer is not the depth of jaundice, the answer is his renal function. So all these things are very, very pertinent to our practice.
So it's all connecting the dots, and now I guess it gives a bigger picture.
Absolutely, absolutely, but also more challenges because these patients, so we are now, it's not uncommon for us to see patients who weigh triple digits, patients who have got very limited physical endurance. And mind you, when you undergo the stress of a major surgery and a long surgery as liver transplant is, it becomes extremely challenging. So you have to work on your patients pretty much running into the transplant.
So someone diagnosed or comes to you with a steatotic liver disease, how do you assess them? I mean, what are the tools required, and do we have all the tools here?
Yeah, so I think the field has changed in this context. So for many years, liver biopsy used to be the gold standard to diagnose this condition. And as you can see on this slide, that it is the amount of scar tissue in the liver which is going to define a patient's clinical course. So the fat is the precursor to the scar tissue, but when you are defining outcomes for your given patient, whether it is the cardiovascular outcome or it is the liver outcome, it is all defined by the amount of scar tissues. So now we have shifted to what we call as non-invasive investigations for liver disease assessment. We call it NILDAs, and that is all portrayed on this slide for your audience. So again, as you can see in this slide, the fibroscan essentially gives you two parameters. One is the quantum of fat in the liver, which is defined by the CAP score, and other is the liver stiffness measurement, which we define in kilopascals. Two molecules are available and we use them based on the patient profile. So these molecules are resmetirom and the GLP-1 receptor agonist like semaglutide. So these are two drugs which are now available for those category of patients who have got at-risk NASH or at-risk MASH.
So let me ask you the $1,000,000 question. Fat accumulated in the liver, can it be reversed?
So that is essentially what you are trying to do in subjects who are not candidates for pharmacotherapy, and that you always do by way of lifestyle changes. So you have to make sure that your patient goes on a hypocaloric diet. You have to make sure that your patient is exercising regularly. You set modest targets for your patients. So I, at least in my clinic, never ever tell a patient that this is your ideal body weight and this is what you have to try to achieve. So as we've discussed earlier, and this is very well highlighted in this slide, the amount of weight that you lose from your baseline, that decides as to whether you will be able to mobilize fat from the liver or not. And even a small amount of weight change to the tune of 3 to 5% from the baseline is good enough to mobilize fat from the liver. A little more weight loss, 5 to 7%, the liver inflammation or all the bad elements which have entered the liver due to the fat, they also start to move away. A little more weight loss, about 10% of baseline, it starts reversing even the scar tissue. So I think this is something which is very, very important for your audience to know and to try to adhere to, that we have to go slow. It has to be done in a sustained manner. It's not like a T20 match. You have to have a kind of a sustainable approach to lifestyle modifications.
So we spoke a lot about alcohol and we spoke about physical exercise as well. So what exactly is the role of diet when it comes to liver health in general?
Yeah, so I think again this is something that we should know, that all of us are actually, we are living in an era of caloric explosion. So probably all of us are eating much more than we ought to. Percentage increase in the steatotic liver disease is far more in Asia than it is in the Western Hemisphere. So that is something that we all need to worry about. When we are talking about diet, the diet which has caught the eyeballs by way of publications is the Mediterranean diet. Now obviously this was, so how did the concept of a Mediterranean diet come about? Because they found that the cardiovascular health of the seven countries in the Mediterranean basin was very different from the mainland Europe and mainland Africa. And what was found is that they had certain differences in what they were consuming. So these are basically, you go away from unhealthy fat, which is saturated fat. Much of the cooking which is done in the Mediterranean basin is by way of olive oil. They eat a lot of legumes, they eat a lot of lentils, a lot of colors on the plate, and then they eat whole grains, And as you can see on this slide, so all the various components that are constituents of a traditional Mediterranean diet are highlighted here. But just to be absolutely honest to your audience, I have also mentioned right at the top the red wine which goes with the typical Mediterranean diet. But I am not advocating that. So this is something that one has to be careful about. Now, compared to the other traditional food substances in a Mediterranean diet, so what you could do is to eat a lot of lentils, legumes. You sift between the cereals, so go for the whole grains. You could use various kinds of millets, go for the brown rice. So we are all traditional rice eaters, so the polished wheat, polished rice, so those are the things that you have to go away from. Then the other things are like cottage cheese, paneer, then soya, that's a very rich source of protein for us. And if you are a fish eater, then fish doesn't hurt. So these could be the Indian counterparts of a typical Mediterranean diet. You have to go on a hypocaloric diet. So how many calories you are consuming at baseline, you have to reduce by a margin of 300 to 500 kcals per day, depending on your activity scale.
So you've clearly mentioned the Indian version of Mediterranean diet and also the magnitude of the steatotic liver disease problem what we are having. So how do you think we all could tackle this, and how do you see way forward?
So as you are aware, our particular center, it's the nodal center for study of fatty liver disease. We have got every tool under the sun that we can use in a given patient, but it's not as if to say that you have to use all the tools in a given patient. So you have things like body composition analysis, non-invasive tests, the VCT or the fibroscan, the MR PDFF, which tells you an exact quantum of fat that there is in the liver, exact quantum of scar tissue that there is in a liver. And if there are competing diagnoses, then you resort to liver biopsy. Then we have got a dedicated team of nutritionists and physiology and exercise personnel who take care of our subjects, because we are also doing a number of key clinical trials in this particular area. And then obviously you follow up these patients, you set their timelines and goals that they need to achieve over a finite period of time. And those subjects who are candidates for pharmacotherapy, you treat them accordingly. We also very seriously encourage our patients to be a part of clinical studies, because in this particular context I would like to have a direct one-to-one with your audience, because oftentimes we Indians think that if you are getting enrolled into a clinical study, then probably the doctor is treating you like a guinea pig. That is certainly not the case. We all must understand that there must have been an era when even paracetamol would have undergone a clinical trial. So whatever medicines any one of us is taking, they all have to go through a clinical trial, and these trials are performed with good clinical practice, and they are very, very closely supervised.
That's absolutely well put up. I think awareness and acceptance is how you have to go about.
Yes. Very, very important, patient participation. So this is one condition where you will not be able to make any headway if the patient is not on your side.
And finally, doctor, on the occasion of World Liver Day, what is that one powerful message that you would like to share with our audience and that they would like to remember for a long time?
The message is loud and clear. We all want to live our lives. So I would say to your audience, live your life, but love your liver. You can't do the former without doing the latter.
So thank you, doctor. It was wonderful interacting with you, and thank you so much for an empowering podcast.
My pleasure. And we'll engage pretty soon on another topic of contemporary interest.
Another day. Thank you.
Thank you.